countries where there are limited resources. And then I also talk about 3 models, which I'll come to in a moment, which is partly why my research is really in line with this. So here is a graph that shows you where most of the births occur. As you know, there are around 140 million births in the world every year, of which 25 million happen in India. India has the highest number of births of any country in the world right now. And for the most part, nearly 1 out of 6 babies, 1 out of 7 babies in the world is born in India. On the other hand, in the US, the birth rate is rapidly falling. And that's creating a lot of concern among pediatricians in the US because as of last year, not many medical students are going into pediatrics because the birth rate is falling so rapidly. And after 2033, the number of deaths in the US will be higher than the number of births. And that's a big concern. And many Scandinavian countries, Japan, and many countries are moving in that direction. So this is where most of the births are happening right now. When you look at it as a per 1,000 population, and this is where most of the neonatal mortality is happening right now. India is part of it, but mainly sub-Saharan Africa and Southern and Southeast Asia is where most of the deaths are happening. Pakistan has one of the highest NMR rates, and so do many of the countries over here. So when you write a program, this book has to be applicable to the more sophisticated center in UK. It also should be applicable to a center in Tanzania with no resources. So writing this book is very challenging. That's where the concept of 2 worlds comes from. The next thing is 3 models. As you can imagine, doing clinical trials in resuscitation is very difficult. You can do it in oxygen, you can do it with cord clamping, but beyond that, chest compressions, there is no real way for you to do a trial in chest compression. And how will you get a consent on these patients? You can't get a consent either. And waived consent is something that we are looking into, but it's becoming increasingly challenging to do research in clinical aspects. So most of the data that you see when you read the NRP textbook, most of the data you see in there comes from animal models, either a postnatal piglet or a newly born lamb. Postnatal piglets are 2 to 3-day-old piglets. They're delivered in the farm. For those of you who are into animal research, it's impossible to do a C-section on a pig. Mommy pigs are really huge and they have a temper. And by the time you get them down, it's very difficult. And they have close to 12 piglets. It's like, imagine going to a delivery with 12 babies, and it's a chaotic thing. I've tried it once and you don't do it. It's really crazy. The only good thing with piglets is that the chest shape of a piglet is just like that of a baby. So to do chest compressions, it's very convenient in a piglet. I do most of my research in newborn lambs. I'll tell you how a Mysore Brahmin got to do research in animal models. That's a long story, and I'll get to that in a minute. But a newly born lamb is like any other baby, has lung liquid, has an open PDA, and behaves really like a human newly born baby in the delivery room. You can put umbilical lines, you can do pretty much everything. The only difference is that it has a keel-shaped chest, almost like that of a boat, and so you can do AP chest compressions. So chest compressions are always done from the side in newborn lambs. So these are the models that we use. And when you read a book of NRP, I can guarantee you beyond oxygen and delayed cord clamping, pretty much most of the other research comes from animal models. So why is that so? If you look at data from Australia, where they maintain very accurate data, where they have close to 600,000 live-born infants, only 10.3% of these infants get CPAP, only 4.5% get PPV, only 0.2% of them require chest compressions, and even a smaller number, 0.05% get epinephrine. So how do you do a randomized trial here? You really don't know which baby requires epinephrine. So for this reason, majority of the data for chest compressions and epinephrine comes from animal models. So this is the algorithm, and I have worked on pretty much every single step of this algorithm. That has been my life's research. And more recently, I've focused on epi, oxygen, and fetal hemoglobin, and we'll talk about all of those as we go along here. And by the way, feel free to interrupt me. Also, those of you who are online, feel free to put your question in the chat, and I can stop and take the question and answer it. So Professor Suman briefly talked about my path, and I never wanted to be a researcher. To be honest, I never wanted to be a doctor at all. My dream job was to be a comics writer. I really, really wanted to draw comics, and that was what I wanted to do. During my days, as both Karthik and Anu would say, we didn't have video games. So there was no video games. All we had were comics and children's books. So that was my dream. And I was literally forced to go to medical school. And I tell my parents that this is my revenge against them to draw illustrations. And that's how I get back at them. So after finishing medical school, I joined as a railway medical officer and then subsequently came back to Mysore to do a residency and then went to Brooklyn to do a second residency and then became a fellow. And I went on a visa called as a J1 visa, which requires that after you finish your training, you have to go and work in a physician shortage area, almost like a small village where you practice as a primary care provider. I did that for 3 years and then went back to neonatology after that. So I've taken a circuitous course, which is typically not what you see in a researcher in the US. Then I became a chief of neonatology. Neonatology chiefs are very powerful in the US because we generate a boatload of money for the hospital. A NICU typically has a profit margin somewhere between 20 to 80 million dollars. That's how profitable the NICU is. Compared to that, the rest of the hospital is in a very bad shape. So the NICU makes money that keeps the rest of the hospital afloat. Sorry about pulmonology and other things, but that's the case with pretty much every single division, maybe except for cardiology and in some institutions where they have a huge cancer program, maybe hemonc. PICU is also self-sufficient but doesn't generate profit. NICU generates a lot of profit. So the CEO of the whole health system knows exactly how many babies are in the NICU. That's what they check every morning. That's how important the NICU is. So when I was a division chief of the NICU, I had a lot of power. And then during that time, I was really fond of oxygen as well. When I became a chair of pediatrics, this position of power went to a position of huge weakness because pediatrics never makes money. And in the US, at least, it's a huge drain on hospital resources. So that transition was very difficult for me to move from one to the other. And then I got really into economics, and then I'll talk about that later. Subsequently, as I got older, I have realized that the most important part of using oxygen is this oxygen blender. And I wish oxygen blenders came with color coding because anytime you use more oxygen, you're causing a lot of damage to any patient, including adults. So you should be really careful when you use, especially more than 60% oxygen. So you should be really careful. So that's my background. And I'm really fond of Phantom. I don't know any of you even know who Phantom is, but I wake up every morning, start with my newspaper strip of Phantom, and that's how I start my day. I really enjoyed reading comics, and that's really my go-to thing. Even today, I read like 3 to 4 comics a week. And I'm also very fond of Chandamama, for those of you who remember that. And there used to be an artist called Sankar who used to draw meticulously beautiful drawings, and I used to copy them, and that's where I learned how to draw. And I do that in many places now. So going back to my relationship with oxygen, when Anu and I were students and doing our internship in MMC, one of our outside community medicine rotations was in VR Hills. So I rotated through VR Hills for a couple of months. And one day my lecturer and all the seniors had gone out on a sickle cell camp. So I was the only one sitting in the clinic. So a guy comes to me and says that his wife is delivering and he needs some help and he wants me to follow. Like an idiot, I pick up my stethoscope. Remember, that's the least useful instrument when you go for a newborn resuscitation. And then I put it on nothing else in my hands. I just jump on the back of his bike and he takes me through dense forest and I'm really, really nervous. I'm a city boy. I've never grown anywhere outside of Mysore. And this is a wild elephant sanctuary, as many of you know. This was deep into the forest. And then off we go. And then he takes me to his place where his wife had just delivered a baby. That actually delivered the baby, led the baby on a mat and had put one of those baskets on the top. So I opened the basket and my heart skips a beat because this baby looks very limp and blue and pale and is not breathing at all. A week prior to that, Dr. Mohan Reddy, as I don't know how many of you remember him, he was a pediatrician he unfortunately passed away in an accident. He was our teacher and he was our NICU doc. He had taught us how to do mouth-to-mouth breathing. This was the pre-HIV days. HIV was around, but we didn't know what HIV was at that time. So I happily gave mouth-to-mouth breathing to this kid. And then to my utter surprise, more than anybody else, this baby turned pink and got better. Although subsequently I heard that the baby died from sepsis. So this was my first independent act as a physician and had an everlasting impression on me. And I thought about it for a long time. So I was making all these calculations. If I'm breathing air in at 21% oxygen, I'm breathing air out at 18% oxygen. How come that 18% oxygen can give birth to, can help a baby? So this is where I started thinking about what oxygen does, and that's what I got into. And since then, I've been working in the field of neonatal resuscitation for a long time. So then I became a PG, and Professor Sonareka Bhatt was my first NRP teacher. She used to come down to Mysore to give some talks, and she gave her one of the workshops on, it used to be called NALS at that time, Neonatal Advanced Life Support. And she gave a course for us, a full-day course in 1992 when I was a PG there. And I'm very happy to see that she got an award recently. I saw it on Twitter, posted by her husband, who also used to accompany her and give us talks on GI topics. So ever since she taught us, we really learned more about it, had these small pamphlets. This book is totally new. This wasn't around at that time. So all we used to get was a 3-page booklet that we used to learn resuscitation. And the only book of neonatology that was around at that time was one written by Dr. Vidyasagar. How many of you have even heard of his name here? Very few, okay. So Dr. Vidyasagar is a neonatologist who is based in Chicago. Throughout 70s and 80s, he brought in pediatricians from all over the world, especially India, and housed them in his own home and trained them for 6 months and sent them back to this country. And he trained neonatologists from Poland, many areas in Europe, and then here. And he, I mean, recently had a stroke and is, but still he's very active. I went to visit him a few months ago, and look at the gleam in his eyes. He's so curious. He wants to do new research. He has new ideas. So he's phenomenal. And he had a book on neonatal intensive care. And there was an old copy of this book in our NICU, and that's what we used to read. And it's a pleasure to work with him and know him more recently. So then I went and joined Railways. I was born in Bangalore. I was born in Victoria. And by the way, I was one of those kids who had neonatal sepsis. I was in Victoria for a long time getting antibiotics. And then thankfully I recovered, one of the odd people to recover from sepsis at that time. And then I trained in Mysore, both my MBBS and MD. And then I went to join the railway hospital in Tamil Nadu, in Tirchi. And I worked there for quite some time. So this was the time when cholera was rampant, polio was very common. We used to admit 6 or 7 patients with polio a day. Measles was rampant. I mean, bronchopneumonia from measles was very common. Marasmus and kwashiorkor were very common as well. And one of my jobs as a railway medical officer was to run this thing called as vaccine on rails. So we used to have a small engine with a thing that went on rails. And we used to take all the vaccines with us and go from station to station and catch out of kids and give them polio drops and DTP vaccinations, etc. So it's really sad that people in the US, who have, many of the pediatricians in the US have never seen a case of measles. They've never seen polio. They've never seen cholera. And there is such a lot of reluctance among parents. I live in California right now, and vaccine hesitancy is a new thing. And that's been around for quite some time, including many celebrities. They don't give their kids vaccine. The principle, these are all not uneducated mothers. These are mothers with education. Many of them are software engineers, very well-to-do people. And their argument is that every other kid surrounding their own child should get vaccine and provide herd immunity for their child. But their own child will not get the vaccine and be open to the risks of vaccine. That's the principle that they follow, which is very crazy. And with increased prevalence of such vaccine-hesitant parents, close to anywhere from 3 to 5% of kids in a given class are not immunized. And that's why you start seeing outbreaks of measles. And with our current administration in the US, which I don't want to go into, but is a major hassle right now, vaccination rates are going to go down even further. And right now, we have a huge outbreak of measles in Texas that's spreading all over the country. And it's really sad to see the hesitancy to vaccines at this time. So then I finished my MD and then went back to working in railways. I was working in Tirchi in Golden Rock Hospital. And there are some nurses here in the audience. And in railway hospital, it's almost like one of those military hospitals where there's a lot of respect given to doctors. And the funny thing was the head nurse would walk around with me with a bowl of I think it was Savlon or Dettol or something like that, and with a towel, and we used to round down these patients, and then it was really interesting, and we had close to a 25-bed ward for pediatrics in this hospital. After finishing this, I went to Brooklyn. This was the only hospital that would give me a second-year position on a phone interview. I didn't have the resources to go for an in-person visit, so I just took telephone interviews and joined there. For those of you who don't know Brooklyn, Brooklyn is the backyard of New York City. and it's one of the roughest neighborhoods that you'll ever come across. So I walk into my clinic, and then a 17-year-old walks in, a black African, really tall, almost like a foot and a half above me, and he's limping and he's bleeding from his leg. And I asked him, "What happened to you?" He said, "I got shot," and he has a gunshot wound in his leg. So I said, "Where did you get shot?" And he said, "Didn't you hear? They shot me right here in your emergency department." So it's a very rough neighborhood, and it took me a lot of difficulty to get adjusted to it. And then my first day in the emergency department, I asked the nurse, "I'm seeing patients, where is my towel?" She almost chewed my head off. And the way it works out in the US is that the nurses rule. Nurses are unionized in the US, whereas doctors are not. To this day, I'm the physician in chief of the Children's Hospital, but I can't admit a patient to the NICU or PICU without getting a nurse's permission. So nurses are very, very powerful in the US. And so it's a big difference between here and there. Subsequently, I went to join my fellowship in Buffalo. Buffalo is a very interesting city. It's literally 10 miles away from Niagara Falls. For those of you who don't know, it's extremely cold in Buffalo. It snows in feet in Buffalo. When it starts snowing, it snows. There are many days when I open my garage door and I can't see the sky because the snow was up to 7 feet out. So I went and joined there because that was the only center that was doing cutting-edge research in surfactant, nitric oxide, and ECMO. And most of the research was being done in sheep models. So when I went to interview, part of my interview was to go to the animal lab. And I said, "No, I'm a vegetarian. I will not come to the animal lab." And Anu knows that I'm really fond of watching movies. Every afternoon after pathology lab, my friends and I used to take a bike and go down to a theater called Sterling in Mysore, where all the new movies used to come. And the path to Sterling was through a big street where all these mutton stalls were there. And I purposefully avoided that and took a circuitous road so that I didn't want to watch them. And then I land up here, and this is like the sheep capital of the country where they do a lot of research in sheep. And I said, "There's no way I'm doing that. I want to be a clinician and get out of here." So I had no intention of going there, and I skipped it. Then I ran into these three people who were my primary mentors. I'm sure you don't know any of them, but Robin Steinhorn is my primary mentor. And they gradually brainwashed me into the importance of animal research. And I'll come to that in a second. So during that period, I wrote my first publication. This was in 1999 on pulmonary vascular biology during neonatal transition. And while writing this paper, I had literally a paper towel from the toilet that I had in my hand. And I was scribbling during a lecture, and I had drawn this figure of how a pulmonary artery looks during fetal life and how it looks during immediate postnatal transition, how it opens up. And I had drawn this, and Robin Steinhorn really liked it. And this was the time when the scanners were not very common. She had her husband buy a scanner, scan it, and then she put that into this paper. And this was my first published figure. The reason I show this is because it's not colorful, it's not pretty, but it shows the concept really well. And she really liked it, and she really helped me get my artistic skills on paper. And now I use Adobe Illustrator. It's a very versatile program that I use, and it's very easy to draw with that. And that's what I use to draw these arteries. It looks more colorful, but the concept is still the same. So subsequently, I had to work as a pediatrician. I went to a place called Pueblo, Colorado, which is a really small town down south. It was really busy. I had two really young kids with me. My wife was doing a fellowship. And that's where I developed my love for oxygen. This was a small town that had close to 6,000 deliveries and two really busy hospitals. And I developed a huge liking towards using oxygen. These were the days when NRP and NALS promoted the use of 100% oxygen in the delivery room. So every baby got 100% O2. And it was nice to watch all these babies come out blue and get 100% O2 and nicely turn pink and look beautiful after that. And because of that reason, all pediatricians in general love oxygen. And in fact, APGAR scores is something that every one of us have given. I'm sure every one of you has assigned an APGAR score. So if you blast the baby with O2, the baby will turn totally red. And why stop at 10? We can go all the way to 11 or 12 or whatever you want. The whole APGAR, as many of you know, she's not a neonatologist. She was an anesthesiologist. And she devised this beautiful score. And there's a lot of history behind that. We'll get to it some other day. But she realized the importance of color as well. And she gave a score of 0 for being blue and pale, a score of 1 when the body is pink and extremities are blue, and a score of 2 when the baby is completely pink. Now that we know how oxygenation works in newborn babies, every single baby at 1 minute of life is blue. If the baby is not blue, there are two possibilities. One, either you are colorblind or the baby is getting oxygen. There is no way a baby can be pink at 1 minute of life, because the average SAT of a normal newborn baby at 1 minute is 65%. And the baby has to be blue. Body being pink and extremities being blue is completely normal acrocyanosis. And to penalize the baby with 1 point for that is totally inappropriate as well. So there are a lot of people in neonatology who are starting to think that APGAR score is outdated, we need something better. But the beauty of APGAR score is that everybody uses it, and so it's very easy to compare from institution to institution and get a score of that. So definitely the color aspect or appearance aspect of APGAR score is basically useless. So I right now live in the Silicon Valley, and for some reason I find dealing with engineer moms very, very difficult. And these moms walk into the delivery room with apps on their phone, and one of the apps thing that you need to enter into the app is the APGAR score. And they get very upset if I tell them the APGAR score is 8 or 9. They feel like the kid has failed its first test. And it's really heartbreaking to see the obsession with APGAR scores. So as you know, there are SAT exams, MCAT exams, USMLEs, and ABP board exams. So we are obsessed with scores, and we should not really penalize babies right at the beginning. And I hope whoever does this app for newborn babies takes out the APGAR score from it. So getting to more serious aspects, oxygen is a really toxic substance. And during my UG days in Mysore, we literally had a bassinet like this. We didn't have any pulse oximeters. In fact, the first pulse ox I saw was the one that Professor Sandreka Bhatt showed it to me in one of the workshops. Until then, I had not even seen a pulse ox until that point. So without pulse ox, all we used to do was put a baby inside this bassinet, connect 100% O2 tank, turn the tank on, wait till the baby gets pink. God only knows what the baby's PaO2 was. And I'm sure we led a lot of babies to develop retromental fibroplasia or ROP at that time, because our rule was that if a bit of oxygen is good, a lot of it should be just about right, and that principle does not work. To this day, this is a clear-cut evidence of oxygen toxicity. There is no other evidence that's as striking as this in any age span, even including elderly people with oxygen. So subsequently, I was very happy as a pediatrician in a small village. You get a lot of importance. It was good, and I decided not to go back to academics and stay as a pediatrician. Then one day, one of my nurses came to me and said that she was reading this is a nursing book, by the way. And she said, I was reading one of my books and I saw your picture, and this little figure that I had drawn earlier was republished in this book. And that made me feel that, oh, maybe I should go back to teaching, and maybe staying here and being a practitioner is not the right thing for me. And after that, I decided to go back to academics and become a neonatologist again. So now I'm really confused as to what my career is. Nobody knows for what I do. Nobody knows my research. Nobody knows my chairmanship. I do a lot of things administratively. Nobody knows any of that. But the only thing I'm known for is pictures. And I have a lot of followers on Twitter. I post images on Twitter, and that's the only thing that gets repostings and things like that. And there's a lot to be said. I draw pictures for a lot of people. And this is a picture of a ARDS in an adult. And we were looking into what happens with ARDS during COVID. And I drew a lot of pictures for COVID at that time. And one thing I feel very strongly about is that when you look at all the books, even the NRP book, every single baby there is a Caucasian white baby, and there is no representation of other cultures. So when I was part of the NRP book team, I told them that I'm very upset that there's not a single African-American baby or an Indian baby or any baby with a bit more melanin than usual in this book. And then they said, okay, why don't you draw a few pictures for us and we'll publish them. And so I made sure that the baby where you see the site of chest compressions looks more like an African-American baby, and the baby who is getting chest compressions looks more brown in color. So that was my contribution to that particular book. And as Miriam pointed out, I had drawn this picture for the phenomenal work that was done in many places, including here. And kangaroo mother's care is such an important thing. And recently, Rudolph's textbook of pediatrics asked me for this image, and this image is going to come out in the textbook. So I have drawn pictures for most of the neonatal textbooks right now. And the good thing is that every time you draw a picture, you get a free copy of the book. So I have lots of free copies of books in my house, secondary to these figures. So if any of you are artists, I strongly encourage you to use your artistic talents to be part of your medical career as well. So okay, getting back to oxygen. So for the longest time, we were using 100% oxygen for term babies. But in 2010, the guidelines changed and it went down to 21%. The problem with these guidelines was that it was done, 21% was across the board was done for everybody, including babies with PPHN, including preterm babies. And I think the pendulum went a bit too far in the wrong direction with that. And here is where you need to maintain sets. And we were just talking about the Dawson curves, and these numbers come from the Dawson curve. So I'm sure you use these numbers as well, but remember that these numbers are done at sea level with early cord clamping. And in my opinion, these numbers are really low. If you use delayed cord clamping, all the numbers will be up by 5 to 10%. So in my opinion, these numbers are very low and these need to be adjusted. But we have very few studies looking at an optimal oxygen saturation with delayed cord clamping, and that's something that everybody is working on right now. So I wouldn't be too surprised if all these numbers change in the next 5 to 10 years and go a little higher. So why is the reason why using 21% O2 does not work for everybody? For example, in term babies, if you give 21% oxygen, this oxygen goes into the alveolus, and the barrier between the alveolus and the capillary is very, very thin in term babies. So it's very easy for the oxygen to go from the alveolus to the capillary, and these babies have a very low alveolar to arterial oxygen gradient. On the other hand, in a preterm baby, remember when you resuscitate a 22-weeker or a 23-weeker, these babies are still in a canalicular stage of lung development. They don't even have nice alveolar sacs, and all you're doing is ventilating their bronchioles. In such a state, there's a huge AA gradient. So if you give 21% O2 in these babies, you really don't get enough oxygen into the pulmonary artery. And so you really don't mediate appropriate transition at birth. So there are lots of trials being conducted now which clearly show that extremely preterm infants, especially those below 25 weeks of gestation, will not do well with 21% oxygen. So the new guidelines that are going to come out in October are going to say that be liberal and use any oxygen between 30 and 100%. So it's totally up to you what you use. So each institution has to come up with new guidelines because in extremely preterm infants, less than 25 weeks of gestation, many people are using very high O2, usually 100% O2, and then titrating down. So with these things, there is now a lot of birth asphyxia all over the world, including here. And the problem with birth asphyxia is that many of these patients with birth asphyxia tend to have a component of meconium aspiration syndrome. And meconium aspiration syndrome is associated with severe PPHN. PPHN is a very common problem in these babies. And also we are seeing a lot of congenital diaphragmatic hernia. I don't know how many diaphragmatic hernias you deliver here, but these are the two indications, leading indications for ECMO in my institution right now. We do around 25 cases of ECMO per year in my hospital, and the only two indications are meconium aspiration syndrome or diaphragmatic hernia. It's very unusual for some of the babies to go on ECMO. So this condition has been something that's very near and dear to my heart, and I've been working in this particular field for quite some time doing research. The problem with PPHN is that when you undergo asphyxia, you develop hypoxia. When you develop hypoxia, you tend to develop acidosis. When you develop acidosis, you tend to cause hypoxic pulmonary vasoconstriction. That in turn leads to reduced pulmonary blood flow. If the pulmonary blood flow is low, you tend to have more hypoxia. This is a vicious cycle in PPHN that tends to get worse and worse. And to break this cycle, you really need to give a lot of oxygen or use agents such as inhaled nitric oxide to break this cycle. So why on earth do we have hypoxic pulmonary vasoconstriction? This is a very conserved phenomenon that has been going on for millions of years. It's present in every single species that has a lung. And the reason why this happens is that, let's say you develop a lobar pneumonia, say for example with COVID, then the alveolus that's totally diseased should not get a lot of blood supply, because if it gets a lot of blood supply, you develop VQ mismatching and tend to become hypoxic. For that reason, God has created a mechanism where the blood vessels adjacent to a diseased alveolus constrict on their own, causing hypoxic pulmonary vasoconstriction. But what happens in babies who have meconium aspiration syndrome or severe BPD is that you have patches of such heterogeneous lung disease in huge areas of the lung. And for that reason, many areas tend to go pulmonary vasoconstriction. And that in turn raises the pulmonary arterial pressure and hits the right ventricle. And the right ventricle is a very sensitive organ. It can't stand high pressures and it tends to fall apart. So that's the problem with hypoxic vasoconstriction. So how much oxygen should we give to prevent hypoxic pulmonary vasoconstriction? The answer to this question was given by Abe Rudolph. Abe Rudolph was a cardiologist. Just so you guys know, neonatologists have contributed very little to the field of NICU. All the important discoveries and inventions have come from anesthesiologists or pediatric surgeons or cardiologists. For example, CPAP was invented or used by Gregory, who was an anesthesiologist. APGAR score, as I told you, she's an anesthesiologist. And Abe Rudolph is a cardiologist who did a lot of neonatal work. ECMO was invented by a surgeon. So this is something that cardiologist gave us. So what he did was he did a simple study using 9 calves where he reduced the FiO2 and showed that if you take the PaO2 below 45 to 50 millimeters of mercury, you see a huge increase in pulmonary vascular resistance. And that was his contribution to pulmonary hemodynamics. So it's very clear that giving appropriate oxygen is a very powerful pulmonary vasodilator. So anytime you go to the bedside and you see a baby who is hypoxic, requiring having low sats, you turn the dial up on the FiO2 and the baby turns pink. And we assume that this is happening on its own, but there's a lot of things happening when you increase the FiO2. For example, when you increase the FiO2, you're giving more oxygen to this baby. This oxygen goes into the alveolus. It's intensely humidified by water. And for that reason, humidification with water makes the FiO2 go down a bit. And it also causes a lot of comfort to the airways. Without this humidification, the airways would literally burn and not do well. Then subsequently, PaCO2 comes through, and that further reduces the alveolar oxygen. And then the alveolar oxygen gets transmitted to the arterial oxygen, and this is where the AA gradient comes into play. And pretty much every single baby that we take care of in the NICU has a high AA gradient because there is some lung pathology going on in these babies. And then you convert PaO2 into SaO2 using the oxygen dissociation curve. And so many of these babies who are anemic really don't do well because you need hemoglobin to carry this oxygen. And so hemoglobin carries a really important role. And both of these, when you multiply hemoglobin content with oxygen saturation, you come up with oxygen content, and that combines with flow, and that decides delivery to the tissues. So tissue delivery is based on a lot of these things. Anytime you turn the dial up, you're initiating this cascade of oxygen that results in increased delivery of oxygen to the tissues. But giving very high oxygen levels also causes oxidative stress. Especially any baby that's requiring more than 60% oxygen should be really careful in these babies because these babies are experiencing significant amount of oxidative stress. So this is where having adequate hemoglobin really comes into play. And we call this COD Wars. Star Wars is a very popular theme among kids in the US. And we are increasingly realizing that having an anemic neonate and giving that neonate a blood transfusion with adult blood is not the same as having a higher level of his or her own blood. So placental transfusion and getting more fetal blood is really, really important in these babies. And that is where delayed cord clamping plays a really important role. And for some reason, deferred cord clamping has not really taken off a lot in the US, in India. But if you think of it, that's how every baby should be born. And there is no reason why you should clamp the cord early in any baby for that matter, unless the baby requires immediate resuscitation. So how long do you wait? That's a matter of debate. The general principle is wait till white. In other words, you have this nice colorful umbilical cord. You wait and let the baby cry for a few minutes till the umbilical cord completely turns pale. When the umbilical cord turns pale, then you know that all the blood from the placenta has come out to the baby. And that sometimes takes around 3 to 5 minutes. But for the most part, most of the transfusion occurs in the first minute or two. And that's something that's really important. And now this has become a big fad. So mothers actually, when they come to delivery, they ask and make sure that the cord is not clamped early because you're leaving out close to a third of the baby's blood with fetal hemoglobin in the placenta. So how does this look? Here is a baby who requires resuscitation. And oops. So you can see this preterm baby has come out here and it's still attached to the umbilical cord during a C-section. Then the baby is not looking great, is not breathing well. So they bring in a mask and then they gave the baby a few PPV breaths and still attached to the placenta. So we let the baby breathe and do resuscitation on an intact cord and let the baby get all the placental transfusions. So need for resuscitation does not have to be a contraindication for placental transfusion because every bit of fetal hemoglobin helps these babies. And the other thing to realize is that if you have these entitled CO2 monitors, the one that changes color, that actually tells you how well the lungs are being ventilated and is actually a good tool to use during resuscitation. So there's a lot of arguments against delayed cord clamping. And if you calculate the number of minutes in 38 weeks of pregnancy, it's 383,040 minutes. So I asked the OBs, what happens if the baby stays on the umbilical cord for 1 more minute attached to the placenta? There's not a big difference between 383,040 minutes versus 383,041 minutes. And you might as well leave the baby for 60 more seconds on the umbilical cord. And all the blood in the placenta is baby's blood. It's not maternal blood, it's baby's blood. And that blood needs to come over to the baby. And this has actually gotten better, except for cases where there is immediate resuscitation that's required. And in these babies, we consider doing cord milking. Cord milking is where you hold the umbilical cord and strip it carefully, and then you can do it 3 to 4 times, and that pulls a lot of blood into the baby. Every time when you strip, you bring in close to 17 ml per kg of blood into the baby. This can be done in term babies, but not in preterm babies. So here is a sample of how it looks in a cut umbilical cord. This is a video from Japan. In Japan, they deliver the baby with a long umbilical cord, close to 35 centimeters long, and then they untwist the umbilical cord and milk it really well and push all the blood into the baby. This is a really preterm baby as well. But in the US, we don't really milk in preterm babies because of some other problems. I'll tell that in a second. But this is what cut umbilical cord milking looks like. What we do is intact umbilical cord, where the umbilical cord is still attached to the placenta. You strip it and push the blood into the baby and let go of this end so that the placenta refills the umbilical cord again, and then you strip again. It's almost like milking a cow. So you get blood from the placenta every time you refill. And that's what we do in the US. So the issue with milking in preterm babies is that in preterm babies, if you milk the umbilical cord, there's a very high risk of developing interventricular hemorrhage. And that's a big issue here. So what happens when you milk the umbilical cord is that what we want to happen is that all the blood in the umbilical vein should come over to the heart. That's what we want to happen. But at the same time, when you're milking the umbilical vein, you're also milking the umbilical artery over here. And when you milk the umbilical artery, there is increased pressure in the umbilical artery. And when the baby is not breathing and has poor respiratory effort, this blood cannot go anywhere else. And all this increased preload blood is diverted towards the carotid arteries, and that results in a much higher increase in blood going into the baby's brain. And a preterm baby who has fragile blood vessels can have a fairly large bleed. So any baby, a preterm baby who's born by, especially by vaginal delivery, who has chorioamnionitis, these babies are at very high risk of developing interventricular hemorrhage, and for this reason, we do not recommend doing umbilical cord milking in babies, in preterm babies. On the other hand, in term babies, it's very effective. And this was a trial that we were part of where giving term babies 4 strips of the umbilical cord milking resulted in reduced HIE, reduced need for therapeutic hypothermia, higher hemoglobin, and reduced respiratory support. So term babies benefit a lot from milking. So if you're not able to do delayed cord clamping, please consider milking. Talk to your OB and see if you can do milking in these babies. Because there is only one blood bank in the world that carries fetal hemoglobin containing blood, and that blood bank is the placenta. You can't go to any other blood bank and get it. Although more recently, people are trying to save the blood from the umbilical cord and do cord-derived fetal blood collections to give babies. That is still under trial right now. It's a little more complicated. I'm not sure if blood bank falls into pathology here, Anu, but if it does, there's a lot of discussion looking into what we can do to collect fetal blood. So to summarize the findings on cord clamping and cord milking, it all depends on gestational age. If you milk the umbilical cord in preterm gestation, it causes IVH, so it's really bad, don't do it. In moderately preterm infants, around 32 to 34 weeks of gestation, it doesn't benefit, it doesn't help. So if you want to do it, you can do it, but most likely we don't do it. In babies 35 weeks and higher, it's definitely beneficial in non-vigorous babies who require immediate resuscitation, because stripping of the umbilical cord takes only 4 seconds. So you can strip the umbilical cord 4 times in like 10, 15 seconds, and then you can resuscitate the babies after that. So the main thing that you need to know during resuscitation is that any baby, preterm or term, if your baby does not achieve a SAT of 80% by 5 minutes, that baby's outcome is not good. So your goal at every single delivery room resuscitation should be to get to a SAT of 80% by 5 minutes, and that requires a lot of coordinated effort. And this is where the importance of giving oxygen comes in. So this got me interested in PPHN, and when I was a final year resident in Brooklyn, I had a really sick baby with severe PPHN that could not be managed and was ready to die. So the good thing in US is that if you call the police and the ambulance people and tell them that you have a sick baby that requires a transport, they stop everything else. This was peak traffic day in New York City, and I had said that I had a really sick baby. I had to take the baby for a 15-mile journey, and they blocked every single street, and we could take the baby over there for transfer. But this baby went there, and this was the days when nitric oxide was still being studied and evaluated. And they put this baby on a bit of nitric oxide, The baby got pink and got better, and that opened my eyes towards research in PPHN. The unique thing with PPHN is that in PPHN, babies are exposed to a lot of oxygen. So it is alveolar hyperoxia and causing oxidative stress in the lung, but the body is not seeing enough oxygen, so there's systemic hypoxia. Similarly, there is systemic hypotension and pulmonary hypertension. So there are all these things that are not working out well. And for this reason, managing these babies is quite challenging, because if you give this baby some dopamine, the dopamine increases systemic blood pressure. It also increases pulmonary blood pressure. So we don't have selective agents. The only selective agent we have right now is inhaled nitric oxide. And for that reason, that's used quite a bit in the US for this purpose. So when I went to Buffalo, that was when there was a model of PPHN being done. It's very difficult to create PPHN in sheep. Sheep, as you know, have quite a bit of temper. To this day, I have done more than 2,000 experiments using sheep models. I never go into the delivery room till the mommy sheep is anesthetized and is on the table, because they can be quite rampant and quite violent. So I have my colleagues from veterinary school that come and anesthetize the lamb for me. Sheep carry a very high risk of Q fever. The amniotic fluid in a pregnant ewe has a lot of Coxiella burnetii spores. So you have to check these lambs for Q fever twice, and only when they're seronegative, you can bring them to the veterinary school. Before we knew this, there are quite a few pediatric surgical fellows and neonatologists that contacted Q fever, and a few of them died. And so sheep labs have closed in the country, in the US. There are only 6 functioning sheep labs right now. And since I do research in sheep, I can only work in these 6 places. I can't go anywhere else. So I've been in Buffalo and Davis. These are the 2 big centers that do sheep research. Then time-dated pregnant ewes are very expensive, because they need to get artificially inseminated, because we need to know exactly what the gestation of the lamb is. And so each pregnant ewe costs $1,800. So these are very expensive studies to do. And so for that reason, not many people do it. The good thing is that if you can do it, telling that you can do it really gets you a lot of money from NIH, because you're one of those unique places that can do it. So this is a model. What we do here is that we go and pull the fetus out and then tie off the ductus arteriosus and put the lamb back in the uterus. And when you put the lamb back in the uterus, this high pressure blood that was supposed to go through the ductus and go to the placenta stops going through the ductus and instead goes to the pulmonary artery and causes rip-roaring, remodeling of the pulmonary arteries. So since Anu was here, I had to put 2 histology slides on this figure. So here are the 2 histology slides. This is a control lamb, the twin where the pulmonary artery looks good, and here is a PPHN lamb where the pulmonary artery is completely remodeled. And so this is the model that was used to do all the animal studies in nitric oxide. So when I was a fellow, seeing these studies being done in the lab, and the same day, using the same tank from the lab and bringing it over to the NICU and using it to save babies was something that was eye-opening for me. And that led me to get into animal research, and I've not been able to scale back from it since then. So what these studies showed was that whether you use 21% oxygen as shown by the green line, 50% oxygen as shown by the orange line, or 100% oxygen as shown by the red line, no matter what you use, as long as you ventilate the lambs really well, you can bring the pulmonary vascular resistance down. And that's the real key. The main thing that you do in NRP is to ventilate the lungs. If you ventilate the lungs, oxygen doesn't matter, although it is important. Ventilating the lungs is really, really important. If you can do a good job with ventilation, you can bring the oxygen down. And what we saw in these studies was that if you use 100% oxygen, you brought the PVR down, but subsequently when you went back and used nitric oxide with these lambs, those lambs that had received 100% oxygen in the past suffered from significant superoxide-induced damage, and so they did not respond to nitric oxide well, showing that prior exposure to 100% oxygen tends to impair your response to nitric oxide. And we all know how nitric oxide works, and it's a selective agent and a microselective agent. And for that reason, it only dilates the blood vessels surrounding a ventilated alveolus. And so oxygenation always gets better with nitric oxide, even though the baby does not have PPHN. So if you start nitric oxide and see the PaO2 go up by 5 or 10 points, that does not confirm the diagnosis of PPHN. The baby might just be having heterogeneous lung disease, and the VQ mismatch might be corrected by using nitric oxide. So nitric oxide is effective in different types of phenotypes. It's very effective when the pulmonary vascular resistance is high. On the other hand, if you have flow-driven pulmonary hypertension or post-capillary pulmonary hypertension secondary to LV dysfunction, nitric oxide is contraindicated. So it's often better to do a quick bedside echo to see what the lung pathology is and what kind of phenotype the baby has before jumping and starting inhale nitric oxide in these babies. And so I don't know how popular Tinder is here in the. Is there Tinder app? There is. Okay, I will not go into that. So it's a very popular app among my residents and fellows, and so I often make fun of them is that if nitric oxide and oxygen are dating each other, then it's not good to swipe right all the time, because the more you swipe right, you'll end up with more and more oxygen, and that's trouble for you. And there are lots of studies showing that although oxygen and nitric oxide are both pulmonary vasodilators, when you have very high concentrations of oxygen, you can form superoxide anions. And when that combines with nitric oxide, you form a toxic substance called peroxynitrite. So when you have any baby on nitric oxide, try to wean the oxygen below 60% as soon as you can, because exposure to higher O2 than 60% and nitric oxide can cause a lot of damage to the lungs. And there are studies showing that maintaining oxygen saturation between 90 and 97% is really good. If you take the oxygen saturations all the way up to 100%, you can cause problem in these babies. So it's really important to avoid very high sats in babies. So avoid 99 to 100% oxygen saturations while managing these patients. Try to maintain oxygen saturation in the mid to low 90s and wean the FiO2 as soon as you can. There are clinical trials that have shown that using more than 60% oxygen along with nitric oxide tends to cause inflammation in the body, shown by increased TNF alpha. On the other hand, if you keep the O2 below 60% and use nitric oxide, the inflammation actually goes down. So the amount of oxygen you give really influences what your response to nitric oxide is in these patients. So more recently, some of my colleagues in Dallas looked at all the babies that died with PPHN. This is a huge delivery center that has close to 10,000 deliveries in Dallas. And what they found was that if you maintain the PaO2 between 60 and 99, maximum PaO2, the mortality was very low. On the other hand, if you had low PaO2 and you were hypoxic, then the mortality was high. On the other hand, if you're hyperoxic with very high PaO2, then also the mortality was high. So having a PaO2 more than 100, especially having a PaO2 more than 150 is not a good thing at all, and you should be weaning these babies down. And if you're only watching pulse oximetry, if the baby is saturating 100%, that baby might have a PaO2 of 60, the baby might have a PaO2 of 600. There is no way to know it unless you do a blood gas. So after doing all this research, I realized that whenever these lambs were being exposed to both nitric oxide and oxygen, their PDE3 levels and PDE5 levels were very, very high in lamb models. That led to more studies using milrinone. And this is where my research went from bench to bedside. And right now, I'm just finishing up a study, a multicenter trial on use of milrinone in diaphragmatic hernia. And I have found milrinone to be very, very effective in babies that are exposed to both NO and oxygen and are not responding well. Milrinone seems to be a very powerful vasodilator in the pulmonary circulation with them. So to conclude, for millions and millions of years, we have been living in situations of starvation. So the human body knows how to deal with starvation, but the human body does not know how to deal with excess calories, and that's where things fall apart in the human body. Similarly, we all know how to deal with hypoxia. By destiny in utero, every one of you was hypoxic. When you were a fetus, I put a pulse ox on you, your pulse ox was around 65%, you're all hypoxic and you know how to deal with it. Whenever you get sick with a pneumonia or something, you develop hypoxia. If you climb the Mount Everest, you'll be hypoxic. So our body is attuned to dealing with hypoxia. We have a lot of defense mechanisms to deal with hypoxia. But there is only one cause for hyperoxia, and that's iatrogenic. Unless you or I give babies oxygen, or any human being for that matter, there is no cause for hyperoxia naturally at all. And for that reason, human body does not have any natural phenomena to deal with hyperoxia. And so that's why hyperoxia tends to be really toxic in babies. On the other hand, hypoxia, just like starvation, can also kill. So you should avoid hypoxia, should avoid hyperoxia. So you have a very narrow therapeutic window when you use oxygen. And to conclude, my take-home points are that the real goal for you when you're doing your MD or DM is to be a compassionate clinician. That's what matters most. If you're not a good clinician, doing abundant amount of research doesn't matter. You should develop your clinical skills first. That's really important. Research really retains your curiosity and makes you humble and gives you a chance to interact with mentors and mentees. And that's the best part of my job. I have 4 primary mentees, all of who have NIH grants, and we have research discussions for an hour every week. And I eagerly look forward to that hour because young, bright people come with new ideas. And however absurd that sounds, there is always something interesting in that. And with being a good clinician, you can change the life of one baby at a time. But being a good researcher, you can influence thousands of babies at the same time. So you have global impact. And you have a unique opportunity to be here in the India. Right now is the best time for doing neonatal research. This is the country where all the births are happening. This is the country where a lot of intellect and new ideas are coming through. And you have the ability to conduct high quality studies at your esteemed institution like St. John's. So please embark on research. I think there's a huge need for multi-center trials to come out of India because what research done in the US does not apply to here. For example, therapeutic hypothermia is extremely effective in US, whereas in some areas in India, it doesn't seem to be as effective. So you need research done at your own institution to tell you what the guidelines should be. And people often talk about bench to bedside. I actually think that it's actually the other way around, bedside to bench, because whenever you round at a bedside, you come up with beautiful new ideas, and it takes you back to your bench to do research. And that's the real fun in doing research. I think I'll stop here and take any questions that you